So we talked about the benign neoplasm and malignant neoplasm of the nasal cavity. In this section now we will talk about the neoplasm of the paranasal sinuses which are present around the nasal cavity, and there are 4 paranasal sinuses. In section 3, we will talk about both the benign and malignant type of neoplasm of the paranasal sinuses. So we will discuss the benign neoplasm of paranasal sinuses, then carcinoma of malignant sinus, carcinoma of maxillary sinus, carcinoma of ethmoid, frontal and sphenoid sinus. So first we will talk about the benign neoplasm of the paranasal sinuses, and then how the malignant neoplasm affect all these 4 paranasal sinuses. So first the benign neoplasm. Benign neoplasm are osteomas in frontal sinus, remain asymptomatic. Obstruction to sinus ostium mucocele formation. And then we have pressure symptoms. So osteomas are the benign neoplasm of paranasal sinuses. They affect the frontal sinus and usually they remain asymptomatic, but once it grows and it causes obstruction to sinus ostium, formation of the mucocele, which is the cyst with the mucus, and then it has, once it grows and bigger, it causes obstruction symptoms in the frontal sinus, and patient feel pressure with the growth of the tumor. Fibrous dysplasia. Fibrous dysplasia is bone replaced by fibrous tissue, mostly involves maxillary sinus. Surgical resculpturing is done. So this fibrous dysplasia is another type of benign neoplasm in which the bone tissue is replaced by fibrous tissue, and it is mainly maxillary sinus is mainly involved with fibrous dysplasia. Ossifying fibromas in young adults shelled out easily. Then we have ameloblastoma, which is known as adamantinoma. Adamantinoma are locally aggressive from odontogenic tissue, invades maxillary sinus, surgical excision. So it's locally aggressive and it's from the odontogenic tissue. Odontogenic is from the tissue around the teeth, and then because the oral cavity is very closely linked to maxillary sinus, so it invades the maxillary sinus, and the treatment is the excision of the tumor. So all these are the different types of benign neoplasm of the paranasal sinuses. Then the malignant neoplasm of the paranasal sinuses. The cause of malignant neoplasm is exposure to nickel and mustard gas. So people who have excess exposure to nickel and mustard gas, they can develop malignant neoplasm of the paranasal sinuses. Adenocarcinoma of ethmoid and upper nasal cavity. Histology is 80% squamous cell type. Carcinoma of maxillary sinus. From sinus lining may remain silent. So let's talk about the carcinoma of maxillary sinus. It involves the lining of the maxillary sinus and it may remain silent or may be asymptomatic. Vague symptoms of sinusitis. It may be silent, no symptoms are present, or vague symptoms of sinusitis like pressure, nasal discharge, stuffiness, all those features are present. destroy the bony confines. Once it forms in the maxillary sinus, it can destroy the bone of the maxillary sinus. Invasion of surrounding structures. Clinical features include discharge paresthesia. Then we have late features include the spreading of the tumor, obstruction, discharge, and epistaxis, swelling of cheek, dental pain, loosening gingiva, ulceration, proptosis, diplopia, and ocular pain, and intracranial lymphatic and nasopharynx spread. All these are the features of the malignancy of the maxillary sinus caused discharge, paresthesia, spreading. Once the tumor spread to the surrounding structure, it can cause obstruction, bleeding, swelling of the cheek is there, dental pain in the teeth, gingival ulceration, proptosis, because now it's spreading to all the surrounding area. So we have the teeth, we have the eyes, orbit, they are affected, there is double vision, there is pain in the eyes. So all these are the features once the tumor or malignancy starts spreading in the surrounding area. Classification is on Gren's classification. Then we have the poor prognosis in Gren's classification is the suprastructural type. Line between medial eye canthus and angle of mandible. So in Gren's classification, the prognosis is poor if it is suprastructural, and in this classification, the line is drawn between the medial canthus of the eye to the angle of the mandible. So this is the area that is involved in the Gren's classification. Then the other is American Joint Committee on Cancer. How they classify it, it's only for squamous cell carcinoma, vascular or perineural invasion, well, moderate, and poorly differentiated. Then we have the third classification, which is Lederman's classification, and in this the two horizontal lines of Sebelet are drawn. One is suprastructure, then we have the mesostructure or the middle structure, which involves the maxillary sinus, and then we have infrastructure alveolar process. So the classification of the this carcinoma is we have Gren's classification, which is poor prognosis if it's suprastructure, and in this classification line is drawn from the medial canthus of the eye to the angle of the mandible. Then the other classification is from the American Joint Committee, in which this is only for the squamous cell carcinoma, vascular or perineural invasion, and this is differentiated into well, moderate, and poorly differentiated carcinoma. Then in the third classification, two lines are drawn, two horizontal lines, and then this divide the area into three sections. We have suprastructure, then we have mesostructure in the middle, and then we have infrastructure. Mesostructure involves the maxillary sinus, and infrastructure involves the alveolar process. Diagnosis is by the radiograph of sinuses, CT scan, best non-invasive method in axial and coronal plane. So CT scan is performed both in axial and coronal plane. Biopsy is always diagnostic of the tumor, whether it's benign, malignant, or it's just the normal growth. Caldwell-Luke approach is the use. Prognosis and treatment. Prognosis is 5-year survival is 40 to 50%. So not prognosis is not very bad. Radiation delivery leads to improvement. Treatment is stage 1 and 2, T3 and T4 lesion is by surgery or radiation, chemo, radiation and infusion of cisplatin. So depending on the stage, the treatment differs in stage 1 and 2, T3 and T4 lesions, surgery or radiation, chemoradiation and infusion of cisplatin. Radiation dose is about 5,500 is given. Next, ethmoid sinus malignancy. This is the tumor, ethmoid area, ethmoid sinus. So ethmoid tumor is present here. Prognosis of ethmoid sinus malignancy is 5-year rate is 30%. So the prognosis is poor as compared to maxillary sinus malignancy, which was about 40 to 50% 5-year survival. In this is 30%. Clinical features: upper nodes involvement, early obstruction, discharge, and retroorbital pain. It's very close to the eyes and its nasoorbital region, so it can cause obstruction, discharge, and the retroorbital pain. If it's late, broadening of nasal root, diplopia, and meningitis. So if it start growing and become bigger late in the time, then it causes widening of the nasal root, double vision, and meningitis. Treatment is radiation, lateral rhinotomy, and total ethmoidectomy, craniofacial resection. So surgery is done by ethmoidectomy and lateral rhinotomy. Next, frontal sinus malignancy. Forehead is involved, there is swelling in the forehead. So frontal, male predominance 5:1. So male are more commonly affected, 5 males and 1 female is affected. Clinical features are pain, swelling, and involvement of the dura mater, which is the outermost covering of the brain and spinal cord. So when the frontal sinus is involved, it can also involve the dura. Erosion of frontal sinus floor. Extension into ethmoid. So it extends into ethmoid sinus. Treatment is radiation and surgery, sinusotomy, resection of dura. Next, sphenoid sinus malignancy. Sphenoid sinus is differentiated. If you see laterally, the sphenoid sinus is located posteriorly. So this is the area of the malignancy. Differentiated from inflammatory lesions. Diagnosis is by plain X-ray, CT, and biopsy. Treatment is sphenoidotomy and radiotherapy. So all these are the 4 paranasal sinuses, and we have maxillary sinus, frontal, sphenoid, ethmoid. All these can be affected by the malignant tumors, and one area, if it's one sinus affected, the malignancy can spread to the different sinuses from that and to the surrounding areas. And since the paranasal sinuses are in the face surrounding the nasal cavity and very close to the orbital cavity, so eyes are very commonly affected. Patients have diplopia and orbital pain, retroorbital pain, depending on the size and extension of the malignancy. So this was all about our lecture in which we talked in detail about the neoplasm, benign and malignant of the nasal cavity, and also benign and malignant neoplasm of the paranasal sinuses, what are their presentations and how they are diagnosed and treated. So thank you for watching sqadia.com.